Welcome everyone to the InTouch Health Webinar Series. This is Scott Young and I'll be your host for this webinar. Today's webinar on how to get paid for telehealth today and what to expect in 2020 is brought to you by InTouch Health, the platform which will virtualize healthcare from the inside of the health system out. Our presenters today are Jordana Bernard and Tim Wright from InTouch Health. Jordana Bernard has 20+ years of progressive leadership in the telemedicine industry. Jordana currently serves as the Director of Policy and Public Affairs at InTouch Health, a leading global telehealth services provider. In this role, Jordana executes strategies for key telehealth advocacy and policy initiatives. Prior to joining InTouch Health, Jordana served as Chief Program Officer for American Telemedicine Association, overseeing strategic objectives to advance the telehealth industry in education, accreditation, practice guidelines development, and alliances with professional societies, governmental agencies, payers, and industry. Jordana received a BS in Biomedical Engineering from Boston University and an MBA from Marymount University. Tim Wright has over 20 years of healthcare industry experience in operations, marketing, strategy, and new product development. Tim was a member of the original founding team at InTouch Health and has played many roles over the evolution of the company. He currently serves as Chief Strategy Officer. Prior to joining InTouch, he worked as an Operations General Manager for what is now HCR ManorCare. He also held positions in marketing, corporate strategy, and new product development at ManorCare and at Marriott International. Tim received an MBA from the Darden School, University of Virginia, and a BA from the University of Washington. We will begin the webinar shortly, but first, a few notices. You have all been auto-muted, but if not, please make sure to mute yourself. You have multiple application widgets you can use, including handouts you may reference throughout the webinar. During the webinar, you'll be able to enter questions in the questions widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to e-registrants. This webinar presentation should last about 60 minutes, including time for questions and answers. And now, I'd like to turn it over to our presenters.
Good morning, everybody. Welcome. We're pleased to have you join us as we provide an update on telehealth payment policy, where we are today, and where physician reimbursement is headed as we move into 2020. Since many of you may not be well-versed in telehealth physician payment, we'll start out with a quick review of where we are today, sort of how reimbursement works. That will be done fairly quickly. Then we're going to move into two major recent policy-related events. One is the recent release of the 2020 Physician Fee Schedule, and second, we'll spend some time talking about new policies that have been introduced, and specifically the Connect Health Act. After those two items, Jordana will unpack. After unpacking these two important policies, we'll spend some time talking about where things are heading from a broader regulatory perspective, trends in the industry with respect to telehealth policy, and then, of course, at the end, we'll save time for Q&A. So as you're listening, if you have questions, don't hesitate to type them in and forward them so that we can be prepared to answer them. As Scott said, if we don't have sufficient time to address your question, I will be happy to do that offline afterwards. I think that's it for the agenda. Let's shift gears, and Jordana, I'll be your wingman here. Let's start by setting the stage. Can you describe the telehealth policy landscape? What legislative and policy changes have occurred at the federal level, say over the last 18 to 24 months?
You bet. Well, Tim, there's been a lot happening at the legislative level we saw the policy landscape really start to take off in 2017, with Congress introducing dozens and dozens of bills trying to remove the barriers to using telehealth that are defined in the Medicare telehealth law. And then in 2018, Congress passed the groundbreaking telehealth legislation in the Bipartisan Budget Act of 2018 and the Support for Patients and Communities Act, which both opened up nationwide reimbursement for telehealth to treat acute strokes, for end-stage renal disease and substance use disorders, as well as for Medicare Advantage plans and for certain types of ACOs. And then at the regulatory level, we also saw HHS and CMS leadership be proactive around expanding access to virtual care by introducing new payment opportunities for communication technology-based services and also for remote patient monitoring. And these services are not constrained by the restrictions defined in the law. And we're seeing these trends continue into 2019. Again, Congress, CMS, other federal agencies, and even the executive branch are all now very engaged around telehealth, trying to remove the roadblocks to make it easier to use and to get paid for delivering these services.
So exciting times, lots of moving parts. Let's stay at kind of a high level and just really as a primer for those that are maybe less familiar, can you give us an overview of the current framework for reimbursement for telehealth under Medicare?
You bet. So the rules for reimbursement of telehealth services under Medicare are defined in Section 1834M of the Social Security Act, which was created when Congress passed the Balanced Budget Act of 1997. And in general, the law allows reimbursement for telehealth when 5 conditions for payment are met. First, it requires the Medicare beneficiary who is receiving care to be located in an originating site that's in a rural geographic area. And this is defined as a site being in a rural health professional shortage area or in a county outside of a metropolitan statistical area. However, due to passage of the Bipartisan Budget Act and the Support Act last year, the rural requirement is waived for telestroke, for end-stage renal disease, and substance use disorder treatments. The second condition requires the patient to be in an authorized type of originating site, and these are hospitals or providers' offices, or in certain circumstances, it can be the patient's home. Third, the distant site practitioner must be an authorized type of provider, like a physician or a physician's assistant or a nurse practitioner. Fourth, because Medicare sees telehealth as a substitution for in-person care, services are required to be delivered using two-way interactive audio-video. And then lastly, telehealth services are limited to the ones that are on the Medicare list, which includes the services that are specified in the statute and other services that get added through the annual physician fee schedule rulemaking process. And so when all 5 of these conditions are met, the distant site provider can bill for the professional fee and the originating site can bill a facility fee.
Okay, so this framework has been in place since since forever, since 1834M was
Right.
Put in place.
Right.
When you look at these different constraints, if you will, to the deployment of telehealth or the payment for telehealth, which one is the most significant in terms of its impact for providers?
Right. Well, I think the geographic restriction on originating sites has the most severe impact. And this is because the vast majority of hospitals and other eligible originating sites just don't meet the rural definition.
Okay, so that's where telestroke and the other recent changes really start to break this down by eliminating the geographic restrictions for certain specific use cases. Let's talk a little bit more about the last one on your list, the CPT codes. Let's drill into that and describe a little bit more what codes are being reimbursed through the existing framework.
Well, in general, there are many opportunities to get paid for initial and follow-up inpatient and outpatient visits, as well as for professional consultations. And currently, there are 98 different CPT and HCPCS codes on the Medicare telehealth list. And the list has been getting a little better every year. And many of the codes on the list describe general services, which allows different specialists to be able to bill using the same code. For example, HCPCS code G0425, which is the first code on the list, is a general consultation code that can be used by a stroke neurologist or a psychiatrist or a cardiologist or any authorized provider who's on the Medicare list for an initial visit with the patient in the emergency department or hospital inpatient setting or skilled nursing facility. There also are focused codes like for telebehavioral health or end-stage renal disease or diabetes management that are also on the list. But the problem is that even though there is this list of opportunities to bill for telehealth, the ability to use the codes is severely constrained by the restrictions that are in 1834M. And as you said, Tim, this is what we're seeing our government aiming to try to fix today.
Great. So what we've described thus far is a category of reimbursement that we're referencing as Medicare telehealth. I think what's very exciting is over the last 2 years, there's been really a policy sea change coming from CMS that apparently is creating kind of new pathways for reimbursement to get around the limitations that we've just described. So CMS has independently created 2 new categories of virtual care reimbursement. It'd be great, Jordana, if you could run through those categories for us.
Right. Well, the first category is called communication technology-based services, and the other is remote physiologic monitoring or remote patient monitoring. Both of these types of services are not considered by CMS to be quote unquote Medicare telehealth, and therefore these services are not subject to the geographic, originating site, and other restrictions that are defined in 1834M. So for calendar 2019, CMS finalized new payment for a number of these types of communication technology-based services. There's the brief virtual check-in, which can be done by phone or video. There's a store and forward visit with an attachment of an image or a video that's sent in by the patient. And there's also new payment for 2019 for interprofessional consultations. For remote patient monitoring, CMS created reimbursement that pays for the technical components of remote patient monitoring and added a new code for the professional services that allows ancillary staff to also provide these services and incident to billing under direct supervision. And again, both of these types of services are not restricted by the Medicare telehealth law, which allows patients to receive these services in non-rural areas and also into their homes.
Great. So we're seeing CMS really proactively addressing the limitations in 1834 by introducing 2 additional categories for reimbursement. Let's stop here for a second and take a moment to ask a polling question. The question is your organization currently billing for one or more telehealth services under these fee-for-service frameworks? And while you're filling that out, we'll maybe continue to chat for a minute, but please respond quickly so we can kind of get your get your point of view, and then we'll share it. While people are filling that out, Jordana, we know about facility fees. Is there a facility fee that gets paid for these newly introduced services?
No, there is not a facility fee for the new communication technology-based services or the remote patient monitoring. CMS only pays for the facility fee when an eligible originating site is hosting a Medicare telehealth service.
Okay. And maybe a second question is, I mean, are they done describing these new categories? Kind of what's CMS's behavior with respect to the introduction of these new categories?
Well, I think we're seeing an evolution to these categories. We saw the two categories get introduced for this year, and in the new schedule we're seeing some changes come about. So I think CMS is really trying to modernize, and we're going to see this happening more and more.
Awesome. So it looks like we have some results in from our first polling question. It looks like of the attendees here, we have over 300 attendees on this webinar, and largely health providers. 51% are saying that they are billing, and another 20% or so are saying they're considering it. So hopefully this webinar is going to help influence your desire to go after billing opportunities. Let's keep rolling. As happens every year, CMS just released the new final rule for the 2020 physician fee schedule. What are the payment policy changes we need to know about, Jordana, with respect to telehealth and these other communication technology-based services for next year?
Well, let's start with Medicare telehealth. Here, CMS is adding a set of 3 bundled payment codes for office-based opioid use disorder treatment as part of a monthly bundled episode of care. And the bundle allows the therapy and the counseling components to be delivered through telehealth without the rural restriction. And it also allows services to be delivered into the patient's home. Again, both of these exceptions to the geographic and setting restrictions have been waived through passage of the Support Act last year. And also, to comply with the Support Act, CMS is establishing another set of bundled payments for opioid use disorder treatments by opioid treatment programs who are certified by SAMHSA. And similarly, the therapy and the counseling components may be provided using telehealth without geographic restrictions and into the patient's home. Of note here, CMS stated that these particular services fall outside the fee schedule, so the telehealth rules in 1834M or the restrictions in 1834M do not apply, and also therefore there's no facility fee. For the second category, communication technology-based services, CMS is removing the administrative requirement to get patient consent for every visit, and they will start allowing a single advance consent at least once per year. And for the third category, remote patient monitoring, CMS is redefining the professional code 99457 to describe the initial 20 minutes of time spent providing services during the month. And then CMS is adding a new code that will pay for additional time spent in 20-minute blocks. Also, beginning January the 1st, CMS will consider remote patient monitoring a care management service, which will change the supervision requirement from direct supervision to general supervision, which is a very positive change that will allow supervision of ancillary personnel through telehealth. And then lastly, CMS is adding payment for online digital evaluation services or e-visits. And these codes will pay for cumulative time spent during a 7-day period by physicians and qualified health professionals, as well as for non-physician health professionals. And these are to connect asynchronously with patients through a HIPAA-compliant secure platform for evaluation, assessment, and management of the patient.
Awesome. So the way I read this, Jordana, is that CMS is taking advantage of the new physician fee schedule to, number one, implement the Support Act, number two, really address some constraints that were existent, around, consent and, general supervision, those items to help kind of free up and make reimbursement easier and more accessible. And then really some more dollars going into specifically into remote patient monitoring to help encourage the use of remote patient monitoring. How would you kind of characterize the impact of these changes for providers?
Well, I agree with everything that you just said, Tim, and I think the reimbursement impact here is big for the telebehavioral health providers and for programs treating opioid use disorders and for providers using remote patient monitoring. And for these two use cases, with these expanded reimbursement opportunities, I think CMS is really hoping that these will create the financial incentives to encourage more adoption of telehealth. And I also think the new opportunities to bill for e-visits are pretty exciting. Here is an example of CMS leadership taking a proactive approach, which you've been saying, Tim. It's really a new day. They're trying to modernize Medicare really by leveraging innovation technologies, and so this is very exciting.
Yeah, I don't know if you have thoughts on this, but when you think about this new e-visit, the introduction of e-visits as a reimbursable activity, what behavior do you think CMS is hoping to encourage?
I think they're really hoping that it'll encourage communication between patients and their clinicians. It's brief communication, and clinicians can total up their time spent during the week. These are time-based codes, so I think it encourages that interaction and trying to get care, at the right time, the right place.
Yeah, I mean, I've heard clinicians sort of talk about, hey, I email or I leave voicemail messages or respond to voicemail messages from patients all the time, but I never was able to get paid for it. So perhaps
Right.
here's an avenue to get some of that back.
That's right.
Let's move on. Let's shift gears and talk about what else may be coming next year. This is a little bit more speculative. So everything we've talked about thus far is policy. Can you review what bills have been introduced to further expand telehealth payment?
Sure. Well, since January, lawmakers have introduced about 50 bills that have provisions addressing telehealth. And I would say the majority of these bills target three main areas. One is removing the rural geographic restriction. One is allowing more services to be delivered into the home. And another one is about adding new types of providers who currently aren't eligible to bill under Medicare. And in terms of trends, the areas that I'm seeing are getting the most traction on Capitol Hill are telebehavioral health services, maternal health services, veterans care, and broadband expansion. And then, of course, just 2 weeks ago on October 30th, the Telehealth Caucus introduced the updated Connect for Health Act of 2019. And the Connect bill is a bipartisan, bicameral telehealth bill that builds on the successes of the previous 2.0 version, which had several of its provisions, including the telestroke and ESRD provisions, signed into law last year in the Bipartisan Budget Act of 2018.
So you threw a new word at it. So this, I've been recently introduced to the word bicameral which I guess means both in the House and at the Senate, and then of course bipartisan, both Republican and Democratic. So what we're seeing is really across the board full support for telehealth as evidenced by the Connect Health Act being introduced. So, I mean, to me, Jordana, this seems like a pretty big deal. You've been sitting in a front row seat as you've seen this evolve with the Telehealth Caucus. Our listeners may not know that the Telehealth Caucus issued an RFI last February, which many of us responded to, and the act as it's now been drafted incorporates a lot of that broad public feedback. So, you know, from your perspective, Jordana, what do you think is the main sort of intent of this legislation and how it's been drafted?
Right. Well, I want to start by saying I completely agree. I think the Connect Act is a really big deal. And I think this bill will likely be the largest, most impactful piece of telehealth legislation in this Congress. And essentially, the Connect Act's 15 provisions, so it's a big bill, aim to remove 1834M restrictions to enable broad use of telehealth and Medicare fee-for-service, as well as it pushes access to telehealth more in value-based care models.
Okay, so let's dive into it, and let's spend the next few minutes here walking through the bill. Can you walk through with us the various provisions?
You bet. So let's start with provisions 1 and 2, which provision 1 basically sets the stage. It gives us the shortened title, Connect for Health, which is an acronym for creating opportunities now for necessary and effective care technologies. And it also provides a table of contents. And then section 2 articulates Congress's findings and conclusions about telehealth, which basically expresses that research has found telehealth services can expand access to care, that they can improve the quality of care and reduce spending. And the sense of Congress is that the barriers to the use of telehealth should be removed.
Okay, so that's exciting to hear that the members of Congress express these sentiments. It's nice to see that they acknowledge the power of telehealth and realize its full potential. Let's go in and drill into the next set of provisions, and I guess we're going to walk through each one so we get a full view of what's being proposed.
Great. Okay. So section 3. This is a very large provision, very important provision. This would give the Secretary of HHS the direct authority to waive 1834M's restrictions on payment of telehealth services when certain criteria are met. In other words, the Secretary would have the ability to waive the rural geographic or the originating site barriers or the restrictions placed on provider types or sites of care, services, and modalities, or actually any other limitation that's identified by the Secretary could be lifted when the waiver is expected to reduce spending but not reduce quality, or the waiver improves the quality of patient care without increasing spending, or when the waiver would apply to telehealth services provided in originating sites in high-need health professional shortage areas. This section also establishes a process for public comments on the waivers, and it requires CMS to post information on the impact of the waivers on expenditures and utilization. And then moving on to section 4, this would create an exception from the rural geographic requirement for beneficiaries receiving mental health services in any of the approved originating sites. The home would also become an eligible originating site through this provision. And section 5 addresses the use of telehealth in emergency medical care. And similar to section 4, This provision creates an exception from the rural geographic restriction for services provided to Medicare beneficiaries in any hospital, critical access hospital, or skilled nursing facility. So this broad policy would allow any specialist to beam into an ED or a SNF to provide an emergency consultation.
Great. Why don't we let's keep going. Can we go to the next set of provisions here?
Okay. All right. Okay. Section 6. Section 6 would require the Secretary to review and improve the process for adding services to the list, the Medicare telehealth list. This provision also requires the Secretary to provide detailed guidelines for the evidence and other information that would need to be included in any public request to add telehealth services. Section 7 would remove the rural geographic restrictions on FQHCs and RHCs to allow these types of facilities to be an originating site where patients could receive care through telehealth regardless of their location. And this provision would also enable FQHCs and RHCs to also serve as eligible distance site providers. And Section 8 also targets removal of the geographic restrictions on originating sites that are Indian Health Service or Native Hawaiian Healthcare System originating sites.
Okay, so we're seeing a continued expansion. Well, so we've got 15 provisions. Let's go to the next step.
Okay, so the next section, 9, would allow the Secretary to waive 1834M restrictions again on telehealth services during national emergencies, disasters, and public health emergencies. Section 10 would allow the use of telehealth to recertify a beneficiary as eligible for the hospice benefit. This provision also requires a report to Congress on the impact of the provision. Section 11 would require HHS to clarify when giving a Medicare beneficiary the technology would not be considered remuneration for the purposes of fraud and abuse laws. So that's those 3 sections.
Okay. Any additional comments about what you think may be most important here?
Well, I think of the sections that we've covered so far, I think the impact of Section 3, where the Secretary could waive restrictions, could be really, really huge. It would depend upon, to what extent the Secretary were to exercise his or her authority to remove the barriers. But I'm hearing the Secretary is very supportive of this provision, and he wants it enacted. And removing the provision from Congress and the whole CBO scoring process, which is very challenging for telehealth bills, and moving it from the legislative level into the regulatory level could significantly help accelerate adoption of telehealth. And I also think the impact of sections 4 and 5 could also make a really big and immediate impact on both patients and providers by increasing access to specialists at community hospitals and SNFs, and allowing providers to implement telebehavioral health and emergency service lines, as well as allowing those who've been delivering these services without getting paid to finally be able to bill and scale their programs.
So maybe one thing to point out here is that there's provision here that gives CMS potentially more authority to kind of expand and evolve. Clearly that's what they're trying to do by creating those 2 new categories. So this gives them a little bit more power in that respect. Does that sound right?
That's right, Tim. That's right.
So maybe just to point out, and we haven't finished going through the Connect Act, but just for reference, I think in the handouts, Jordana, didn't we put some information about the Connect Act?
Yes, we did. We've included the bill language as well as a summary of these provisions. I know we're going through a lot here, so there's a handout that kind of walks through each of the provisions in the bill.
Okay, so you may want to refer to that, folks, if this is too quick of an overview. Let's pick back up where we left off and go to the next set of provisions.
Okay, well, this is the last set of provisions. Section 12 directs a MedPAC to conduct a study and provide a report to Congress on the use of telehealth in the home. Section 13 requires the CMS Innovation Center to study and report to Congress on the telehealth waivers that are used in alternative payment models and the impact they're making on quality and spending. Section 14 authorizes a new Innovation Center model using telehealth that would include additional types of practitioners not currently defined under Medicare. And the last provision, Section 15, basically articulates general congressional intent for the Secretary to test more models under the Innovation Center to evaluate telehealth under Medicare.
Okay, so those are the 15 provisions. Is there any other kind of element that you want to highlight with kind of from a perspective of a main takeaway?
So I think for me, the main takeaway here is that Congress is really trying to remove the restrictions, especially the big restrictions. And I see these are broader policy areas. You know, last year it was telestroke and it was substance use disorders, and these are narrowly focused use cases. But these are provisions that can make very large, big changes and really help to accelerate adoption of telehealth.
Yeah, that's a great comment, Jordana. And you know, from I think from our earlier discussions, it feels like you know, if you step back 2 or 3 years, there was still a lot of hesitation about moving forward aggressively with telehealth. We've now kind of flipped to, you know, last year and the year before it was how can we pick a few, you know, horses like telestroke and get legislation passed on that. And now it's more, okay, we've really got to drive changes more aggressively and more holistically so that we give the tools to providers and organizations to really leverage telehealth as a way to reduce cost and improve quality and access. Is that fair?
Absolutely, most definitely.
So let's now talk about what's next for the Connect for Health Act. What's next in the process? So this has been introduced. What happens now?
Right. So now that the bill's been introduced and referred to the committees of jurisdiction in both the Senate and the House, the hope is that it will gain traction and move through the legislative process and then ultimately move to passage and getting signed into law.
Awesome. So that process is going to take some time, and let's introduce a kind of a polling question here. So the question is, are you interested in learning more about advocacy efforts to advance federal health legislation, including the Connect bill? And I'm going to warn you, if you say yes, Jordana and I are going to reach out to you because we're always looking for you know, more people to support the advancement of telehealth as we you know, draft language and participate in polls and the caucus and so forth. So we're interested in your in your interest in getting involved in advocacy efforts. You know, just while we're gathering that data here, you know, we've spent quite a bit of time working on this stuff, and really the single most important thing, and Jordana and I didn't talk about this in advance, but it is really getting new legislation scored through the CBO and CBO prescribes kind of a cost or a benefit to the federal budget, and getting evidence that in fact telehealth will actually reduce cost, not increase cost, and will drive increased value from a federal perspective. So that's one area where we're particularly interested in help, because getting that evidence and that data for the CBO is critical to advancing legislation. So, other than that, Jordana, do you have any comments about what stakeholders can do to help with the Connect Act?
You bet. Well, advocacy is really important to help build the support and momentum behind a piece of legislation. And so stakeholders can really, do a lot by reaching out to the bill sponsors, to Senator Schatz's office, to Rep. Thompson's office in the House side, to endorse the bill. And then also, it would be super helpful, if groups would contact their state senators, their representatives, and educate them around the Connect bill, and try to get them to support the bill. So we need to build up the co-sponsorship behind it. And the more co-sponsors we have, the more momentum behind the bill, the better it is. And so advocacy is a big part of what we do. And as Tim said, we would very much welcome the opportunity to partner with our colleagues here in the industry to help move the bill forward.
Okay, so we've got the results up on the screen. Let's move to the next topic, which is really value-based care. We've been talking all about traditional fee-for-service payment. There's been increasing interest, obviously, at the federal level about driving value-based care models. Can you tell us from a high level what role telehealth can play in value-based care delivery models?
You bet. Well, fundamentally, I think telehealth can play a big role in value-based care because it allows all entities to work together to drive better, more efficient, cost-effective care. However, I think it's also important to highlight that while the industry is transitioning to value, we need payment changes to enable telehealth and fee-for-service now, because it's still the main way providers get paid, and it's going to be around for a while. So I think it's very exciting to see that our government understands the importance of getting telehealth adopted now, and how it can save money and provide better care in fee-for-service. And I think this is really significant because it's something that previous administrations have really resisted. And then with telehealth in place, healthcare systems will be ready to leverage the benefits of telehealth and value-based care models. Okay,
so let's dive in a little bit and talk about the current opportunities to leverage telehealth in value-based care.
Okay, well, one of the most important ways to leverage telehealth is in Medicare Advantage plans. And on January the 1st, the rules around the use of telehealth in these plans will change significantly due to passage of the Medicare Advantage provision in the Bipartisan Budget Act last year. And so just to give a little bit of context, today there are about 22 million Medicare beneficiaries who are enrolled in these types of private plans. So that's just about over a third of the Medicare population. And the way it works today is these Medicare Advantage plans provide comparable coverage of telehealth benefits to those benefits that are included under original fee-for-service Medicare. And when a plan wants to offer additional telehealth benefits that go above this basic level, such as allowing Medicare enrollees to receive services in urban areas or at the home, they have to do this through supplemental plans, which get financed through premiums or through rebates. With passage of the Bipartisan Budget Act, Medicare Advantage plans will have the flexibility to build in these additional telehealth benefits into their basic plan bids rather than having to do this through supplemental benefits. And so we'll see, how quickly these opportunities get adopted and implemented by the plans. But as plans adopt more telehealth, the opportunities for providers to use telehealth and get paid will also expand. Another way to leverage telehealth is in accountable care organizations. However, to date, the ability to use telehealth has been, pretty limited as well, except for a few types of ACOs like the Next-Gen ACO. The Bipartisan Budget Act also changes this beginning on January the 1st, when other types of performance-based ACOs will have increased flexibility to use telehealth to treat their patient populations also in urban areas and in the home. And then under the CMS Innovation Center, there are a number of models that allow the use of telehealth. There's the Comprehensive Joint Replacement Bundled Payment Program. There's the Bundled Payments for Care Improvement Advanced Program, or BPCI Advanced. And both of these programs offer a telehealth waiver that allows providers to deliver services, again, in non-rural areas and also into the patient's home. There's the VBID model, which is the Medicare Advantage Value-Based Insurance Design model, which is testing increased access to telehealth services to meet requirements for provider network adequacy. There's also the ET3 model, which is Emergency Triage, Treatment, and Transport, which will be kicking off soon, and it will allow EMS personnel to use telehealth in the field as a way to prevent trips to the emergency department. And there are also new kidney care models that will go live next year that will allow the use of telehealth in any geography. And so what we're continuing to see, Tim, in these value-based and capitated models is when providers assume more risk, the government allows more flexible use of telehealth.
So if someone wants to take advantage of one of these CMMI models, do you know can you just participate, or how does it work?
So they would need to apply. So that's something that they could go up to the cms.gov website and look up the model and get all the information, and it's something that you apply for.
Okay. So we want to do another polling question here just quickly to see to what extent our attendees here are participating in value-based care delivery models and billing under those models. So are you currently using telehealth in any value-based care delivery models? And while folks are responding to that, it just feels like, again, the aim here is to encourage the adoption of telehealth, but at least with respect to Medicare Advantage plans, the goal here is to get telehealth incorporated in plan design right from the beginning. What's your sense, Jordana, from a Washington perspective, and maybe from a state perspective too? Is value-based care gaining more momentum? What's happening?
Yes, I think it's definitely gaining momentum. We're seeing the governments accelerating their efforts to push the industry in this direction, for sure.
Okay. It felt for a while, particularly when the new administration came in, that it was kind of waning. But so the heat's back on to try to drive value-based care payment models. Here's should we share the poll results? So looks like we're down about 25% are pursuing value-based care delivery models using telehealth, and maybe another third or so are contemplating that. So let's continue kind of focused on the future here. What else are you hearing from the Hill about other bills that might get introduced?
Well, I'm hearing about a number of bills that where there's interest around introducing new legislation for telebehavioral health services in the emergency department and also for ambulatory care. I'm also hearing interest around reintroducing the RUSH Act, which expands access to telehealth and skilled nursing facilities, and this is to try to reduce hospital readmissions. There's also interest in finding solutions to pay for telehealth technology. And there's interest in coordinating telehealth research efforts across all federal agencies in order to build up the evidence base for telehealth to help drive policy reforms. And I've also heard the House is considering introducing another telehealth bill with provisions that just didn't make it into the Connect bill.
Okay, so bunch more stuff that's gaining some momentum in various parts of the House and the Senate, huh?
That's right.
So let's step back. We're running up against our timeline here. What do you think all of this means for health systems? How would you interpret what's going on?
Well, I think the payment landscape that we've been discussing offers opportunities for providers to use virtual care and to be able to bill for services that have been provided for free in the past. In particular, providers can take advantage of nationwide reimbursement for telestroke services, for ESRD, for substance use disorder treatments into the home. And there are these new opportunities to get paid using the communication technology-based services and remote patient monitoring that are not subject to the 1834M's restrictions. And then beginning in 2020, the new Medicare Advantage, ACOs, and the physician fee schedule payment changes will also go into effect, bringing more ways to use telehealth and get paid. And so I think these are really big shifts, Tim, that we're seeing, and there's no question that the industry is evolving more rapidly now. The policy landscape is evolving. So I think it's important for providers to be proactive and to get familiar with these changes and opportunities in order to be able to take advantage of them.
So this is it's exciting. We're seeing momentum. Where do we go from here? What can we anticipate happening here in the near term?
Well, I think, you never know, but with the aging population, federal healthcare spending at unsustainable levels, and the promise of telehealth, certainly passing the Connect for Health Act offers Congress an opportunity to get a win in spite of the challenging environment on Capitol Hill these days.
All right, so because we're kind of beginning to run out of time, we do want to touch on these other federal regulatory actions. Can we spend a few minutes on other stuff that's happening at the policy level that isn't directly related to reimbursement?
Absolutely. Absolutely. So let's just highlight some of the regulatory initiatives that will impact telehealth that are important to be aware of. First, there's a major effort underway in CMS and ONC that targets data sharing and interoperability in healthcare. Both agencies have finalized a set of rules that are anticipated to be released soon and possibly by end of the year. And I think the combined rules will have significant implications for payers, healthcare providers, and health IT vendors. So that's something to pay attention to. We're also seeing initiatives coming out of HHS's Office of the Inspector General, this is the OIG, and CMS to modernize the anti-kickback statute, the Stark Law, and the Civil Monetary Penalties Law. And all of this is to help promote coordinated care, high-quality patient care. And both the OIG and CMS have released companion proposed rules that outline safe harbors and exceptions, which addresses when technology can be given to patients without being considered remuneration, which would violate the laws. There's also an effort underway to review and modernize HIPAA. We've seen proposed rules come out from the FCC about a 3-year, $100 million pilot program to fund broadband services to support telehealth. We've seen the FDA come out with a set of companion guidance documents on digital health. There's also the recent presidential executive order on Medicare that pushes HHS to increase adoption of telehealth. And lastly, we anticipate release of the DEA's proposed rules that implement the special telemedicine registration, which will help make it easier for providers to prescribe controlled substances using telehealth without the initial in-person visit. So Tim, I think the message here is there's a lot going on at the regulatory level that will impact stakeholders in the industry in the near term.
Yeah, and these are huge categories of discussion, each one of them independently. Let's do another quick polling question. I know we're reaching the end of our time. And the question really here is regarding future webinars. If we were to revisit those topics that Jordana just described, please indicate your interest in future webinars on those topics. So we're giving you some options here. Obviously, we're doing work to kind of keep up with what's happening in each of those categories. So please let us know which are most important or most interesting to you. Jordana, maybe we'll take a minute here just to review the handouts that are available. Do you want to just take a minute and talk about what's available?
Yes, absolutely. So what we've provided first is the Medicare telehealth fact sheet for 2019. So that shows the current requirements that we've been discussing for Medicare telehealth. And then we've also included the CMS 2020 physician fee schedule final rules, along with a summary of the rules that impact telehealth. We've included the Connect bill language and also a summary of the provisions of the bill.
Excellent. So, and then we've been receiving a large number of questions. Given that we're almost out of time here, I think what we'll end up having to do is respond to you individually with answers to those questions. So we apologize that we're running up against our time. Maybe as we sort of bring things to a close here, and you want to show the polling results just so everybody can see. So I think all of those topics are of interest to those of us in the field, and we'll take that feedback, and we appreciate it. So we've covered a lot of ground today, and a lot of information. Jordana, do you want to kind of make some final comments here about what you think the takeaways are for our audience?
Sure. So I'll end by saying I think we're making significant progress, and we're going to continue to see reimbursement evolve, but at a more rapid pace because of this major governmental support that there is for telehealth today. It's really a seismic difference from just a few years ago. It feels like today the government is really working with us to move telehealth forward. And so I think it's a very exciting time for our industry, and let's continue to work together to keep the momentum moving forward towards broader expansion of telehealth and bringing healthcare to patients the right time, right place.
Well, that's a great closing statement. Again, apologize that we've run out of time. We will get back to you with answers to your questions. Jordana's going to be busy. There's a lot of questions. And we appreciate your involvement. Again, if you have additional questions, or if you'd like to connect with us around various policy initiatives, would welcome your participation and involvement. And I guess on that, we'll thank you, and we'll see you again soon.